talking about pediatric and family-centered care today. It's going to be a little bit different probably from some of the other presentations you have heard. It's going to focus more on softer skills of nursing because you've gotten a lot of information about other things, and like radiation dermatitis care is the same, whether it's adult or pediatrics, in terms of how you want to manage it, just your approach about how you want to manage it, how you want to approach the patient might be different. So it's going to be more on the soft skills and philosophy of care presentation today. What we're going to focus on, the big real take-home points are kids are not little adults and that kids require different care. So under the kids are not little adults, we're going to talk about developmental differences with children, physiological differences, disease differences, and then some radiation differences as well. So I'm not going to go through all of these words, but it is, as I believe the slides will be available afterwards. If not, we can make them available. But it's important to remember that there are developmental differences with children when you are taking care of them. It really affects how you approach and how you talk to the child. There are physical differences, and what I have listed here is just like what you would expect for normal ranges of weight gain and height increases at the different stages of development. There are fine and gross motor developmental changes in terms of like when they can actually use their hands, how they can use a pencil or a crayon. Can they be expected to walk alone? Can they walk up and down stairs? Those all tend to progress on somewhat normal timelines for children, although medicalized children can be different. They might fall in normal ranges, but you also might see that they regress. If they have achieved some milestones, they might lose them during their medical treatment. They might also be more advanced on some milestones than some other children, especially on some of the more cognitive and social development skills, because they are spending a lot of times with adults in the medical facilities with their parents, much more than the average child would be, who might be spending more time with their peers at school or just hanging out with friends. So they can be on the normal timeline, they can be advanced, and they can be regressed, and the same kid can be in all three areas at once. It is important to know where they are, and as a pediatric nurse, especially in something like radiation, where you're going to see them repetitively over a course of time and not just a one-time visit, you do want to try and be aware of their developmental milestones and try and keep them on that trajectory if you can, even while they are getting care. In terms of physiological differences, children have larger body surface area, their skin is thinner than the adults are, their metabolic rate is higher, and it can vary during different growth periods. So how they metabolize drugs and how they heal and things is a little bit different. And then the big thing when you're providing care with kids is that they have much smaller airways. So especially if you're giving radiation in the airway area or anything going on, their most likely reason that they're going to get into distress is going to be respiratory. Unlike adults whose most common issues are going to be cardiac as a first concern, children are going to have respiratory issues before they get cardiac unless they have some sort of congenital abnormality with their heart. It is a good idea to have some sort of normal standards for what you think is baseline for different developmental ages, because infants will have faster heart rates, they will have lower blood pressures, they will have faster respiratory rate than an older child, and those do change as they grow. Here we tend to use PALS, which is from the American Heart Association, but there are different scales. There are different things you can access if you don't currently have something, to have some sort of standard. Children are also more susceptible to fluid loss, so they can be more susceptible to hypothermia. And then the other thing that's unique about children in terms of physiological differences is they tend to compensate a lot longer than adults will. The changes that you notice in them physiologically will be much more subtle. So declines can seem very sudden if you're not really watching them carefully. It's something we always talk about with our parents and our new nurses who are dealing with pediatrics, is if a parent tells you something like is off, you really want to listen to them, because a lot of times the parents will notice something very subtle. Maybe their heart rate hasn't dropped yet, but it's just about to, and the parent has just known that the kid is acting a little bit differently, and you should be listening to that. Now, sometimes it can be behavioral, sometimes it can be stress, but sometimes it can also be the start of something physiological that is the parent is picking up but can't necessarily verbalize yet, or maybe you're picking up but don't quite know exactly what's going on yet, and then they can go down pretty quick if they get sick. So a child is receiving radiation and experiences a medical emergency. Which is the most likely cause? A, too high a dose of radiation, B, too much anesthesia, C, cardiac event, and D, respiratory emergency. And the answer is D, a respiratory emergency. If there's something miscalibrated with your radiation machines, they definitely could get too much of a dose of radiation, but that's likely not going to cause an acute emergency. And too much anesthesia, if your anesthesiologists are titrated too long, hopefully doesn't happen. It could happen, but the most likely thing, if nothing is going wrong in a patient's care, is a respiratory emergency. Their airways are very small, and any sort of swelling, including just getting a virus or a cold, can really compromise and cause a medical emergency, which then can lead to cardiac arrest. There are some physiological disease differences for kids. A lot of times when patients and families come in, they will talk to us about how grandma had cancer or their great aunt had cancer or something like that, so they know what this experience is going to be like. We do have to talk with our patients and families to let them know that the experience in pediatric cancer, the diseases are actually tend to be different cancers. They're just different disease processes. Children tend to have much more acute cancers, and part of that is their metabolic rate. They are growing faster, the tumors are growing faster, everything in them is growing faster, which is an advantage in some ways because chemotherapy and radiation attack rapidly dividing cells. So you can see a great response in kids with cancer that you might not see in an adult who's had a tumor growing over 10 or 20 years. But it can also be more challenging because kids can die much quicker from their cancers if we're not aggressive with their treatment, because the cancers will grow very quickly. So these are not all of the different cancers you might see in kids, but these are some of the more common ones we see in the radiation field. Rhabdomyosarcoma is from a mesenchymal cell origin, most often from the skeletal cells. In infants, it will present in the vagina or bladder. For kids that are less than 8, in the head and neck, and that's the population of rhabdomyosarcoma patients that we tend to see most at the proton center. And then in adolescence, it can present in the extremity. Most patients who get rhabdomyosarcoma will receive radiation, and the majority of rhabdomyosarcoma patients will be diagnosed before the age of 9. Ewing sarcoma is one of the bone tumors. It can also invade the soft tissue as well. If the patient's going to get radiation, if they have Ewing's, depends on the location of the tumor and the response to chemo. It's most common in kids 10 to 19 years old and the second most common bone tumor. Neuroblastoma is usually found it's of the neuroclast cells, and it's usually found in the neck, head, and or abdomen, arising from the adrenal gland. Radiation is usually recommended post-surgery for neuroblastoma. It's the most common extracranial tumor, so outside of the skull, and the average age at diagnosis is 19 months. These are young children for the most part. And if you're seeing a high-risk neuroblastoma patient, you will likely see them at the end of their cancer journey, but that is a long journey. They're getting diagnosed young, and sometimes they will be in a treatment just as long as they've been almost half of their lives, because that treatment is at least a year and a half, and they will get chemotherapy, radiation therapy, immunotherapy, 2 stem cell transplants, and surgery. We do all of the modalities for the high-risk neuroblastoma patients. So by the time they get to radiation, they tend to be pretty medicalized and can be really off some of those developmental trajectories. Wilms tumor is a renal tumor that peaks at the age of about 2 or 3 years old. It's rare in children older than 5. The entire abdomen might get radiated if there was tumor spillage or diffuse peritoneal seeding. And lung radiation may also be recommended, as that's where it tends to metastasize to, and they might have tumors at diagnosis. Medulloblastoma is one of the more common brain tumors in kids that we will see for radiation. It's 20% of all childhood tumors. It's most common tumor of the central nervous system, and proton is usually used for the deep tumors not amenable to surgical resection. So those are just some, but there are more that are pediatric specific cancers. You won't see breast cancer in a kid. You won't see uterine cancer. You're not going to see prostate cancer. Those don't happen in children. Some differences for radiation. For brain tumors, even if we know that specific brain tumor is very susceptible to radiation and will be killed off with radiation, we usually will do anything we can to delay their treatment until they're at least 3 years old. So we'll try and give them chemotherapy or potentially some immunotherapies to keep their tumor from growing until they're at least 3. The reason for that is when you radiate a brain that has not developed past 3 years old, they are never going to live independently. They are never going to progress to the age where they will need to have they will basically be 3 years old for the rest of their lives in cognitive development, maybe a little bit older, but they will not be able to function as an adult in society. Here in Seattle, we try and delay up to 5 years if we can. We have some different, we call them baby brain protocols with chemotherapy to try and get them in remission temporarily, even if we know the tumor will likely come back so that they can develop and grow to be older and have more advanced brain structures. We will talk about cure in pediatric radiation, not just remission, not just control, but sometimes we will also talk about cure, which isn't always the same with adults. The other big thing is that radiation can really impact growth and development. So if a kid is still growing and you radiate them, you can have bone hypoplasia as low as 10 gray. For skeletally immature patients, you want to limit sharp gradients across their vertebral bodies to reduce scoliosis. So an adult, you might draw a really sharp line to preserve as much healthy tissue as possible. In a kid, you're not going to necessarily do that because if they're still growing, the side that you radiate is not going to grow as much as the side you didn't radiate, and that's going to produce scoliosis and lifelong problems. You usually cover the healthy portion of the spine at about 85% of the prescription dose. You can use wrist radiographs to help in determining the remaining potential for growth if you're unsure if they're an older child. And then you can also, even before you get to wrist radiographs, just look at their parents and see where they are in height. But the wrist radiographs will give you more specificity about how far they are in their growth curve. Breast tissue growth can be affected in as low as 10 gray. So for kids, you want to consider the nipple and breast tissues as organs at risk and trying to avoid them if you can. Testes can be affected as low as 1 to 2 gray. 3 to 4 gray can have some recovery after 4 to 5 years. 12 gray can cause permanent azoospermia and testosterone is decreased. And greater than 24 gray will need testosterone hormone replacement. And then the ovaries are also at risk. For prepubertal dose of 10 gray can create sterility in a patient. And then age 15 to 40, 2.5 gray can cause about 60% sterility. 5 to 8 gray can cause 70% sterility, and greater than 8 gray is 100% sterility. So those are measures you might have to think about that you don't necessarily think about in some of the adult populations, especially the older adults. But children are very resilient and seem to be more robust in ability to recover from treatments. A lot of our parents, when they come in, they start asking when that fatigue is going to kick in because the kid's still running around the center and having a good time, and they'd like a break to have the kid be a little bit more tired. So those are the really describing that the kids are not small adults part of the discussion. They are physiologically different, they are developmentally different, and you do need to plan their care a little bit differently in terms of the actual treatments delivered. But then the approach of how you treat children is very different as well. We're going to talk about developmental care, family-centered care, and atraumatic care, which are the 3 big things you hear about in pediatric nursing. So in terms of developmental care, you want to think about where they are in the developmental spectrum. What you don't want to try and expect more of them than they are physically capable of doing at their age. But some general things that you can do for any child of any age, and even adults too, is avoid standing over the patient. You want to get on their level. This is a picture of Erin, one of our child life specialists, which I'll talk more about what those are a little bit later. You can see this is actually in our simulation room, and they've developed, they have a toy simulation machine and they have a doll on it. You can see Erin has gotten down she is kneeling at the level of the child. That is a lot less scary for a kid to have somebody hovering over them. You seem more like a peer. You seem more interactive and friendly, less intimidating and authoritarian if you are standing than when you're standing over them. Incorporating play and providing choices is huge in the care of children. Here she's playing with a doll. They're going to go through the mock simulation. You can even see we've made doll size radiation masks so that the child can practice putting it on the doll first before the child has their own radiation mask made for them. And choices are huge. Kids, especially when they're in a medical environment, but for the most part, they have very little autonomy. Their parents make decisions for them. They don't necessarily get to decide when they go to bed, when they get up, when they eat, what they eat. So they don't have a lot of autonomy on their own. And especially at different developmental stages, they're going to be really trying to test for their independence. So providing choices is a huge part of pediatric care along all the different developmental spectrums, but you have to think about the choices you provide because you have to accept the answer they give you. So you don't want to walk into a room and say, can I take your vital signs now? Because if they say no, you have to honor that. If you don't honor that, you've lost their trust and you're likely going to lose their compliance. But what I do is I walk in and I say, do you want to do your blood pressure first or do you want to do your pulse oximetry first? So they're getting a choice. They get to control. And then if they choose their blood pressure, do you want to do your right arm or do you want to do your left arm? Or if they're little like toddlers, sometimes do you want to do your leg? So you're giving them some autonomy, you're giving them some choice, you're showing that you respect them and that they can learn to trust you, especially if you honor their choices. And there are very easy ways to give children choices the whole way through treatment. You want to be truthful, but gentle. You don't ever want to lie to a kid, especially a little kid. You're not going to get them back. They're not going to trust you. And they will also consider omitting things lies. So I will never tell a child something's not going to hurt. Even if I'm almost positive it's not going to hurt, I will say things like, this usually doesn't hurt. Most kids say that it's fine, or if I'm cleaning for like a port access or central line or a dressing change or something, I'll say most kids will tell me that it's just cold and wet and maybe smelly, but that it doesn't hurt. The reason I don't ever promise it's not going to hurt, because every once in a while you'll have a kid with a skin tear or super sensitive skin, and that's going to be the one kid that's going to now not trust you because it's not going to hurt. But you definitely don't want to say it's not going to hurt if it is, especially if you're doing an injection, a port access, something like that, that's going to be a poke. It will get you through that first one quickly if you say this is not going to hurt. It will be much easier. They'll be much compliant because they're gonna trust you and they're gonna think it's not gonna hurt. And then when it does hurt, they're never gonna trust you again. And not only are they not gonna trust you again, they're not gonna trust another nurse again. They're not gonna trust anybody who says it doesn't hurt in the future. So you do need to be truthful to them. And then you need to give them time, especially in the beginning. And this can be a very big challenge. We actually bring the kids in for anesthesia over a half an hour before their treatment time to give them time to do their vitals, to give them time to adjust, to talk to them, to get them ready to bring into the room. And then some of the kids who aren't in an anesthesia, we have them come in early to talk to the child life specialist too, especially on their first day. Giving them that extra time and not having to force them through it in the beginning will make every interaction after that a little bit easier. You also want to use simple, age-appropriate language and avoid medical jargon as much as possible. I have some examples of that for future slides. You want to use active listening. You want to listen to them. They want to be heard. If they feel like they're not being heard or you're ignoring them or you're only talking to their parent, they're going to not trust you and they're not going to work with you. Asking kids about their interests or hobbies can help build rapport very easily, and it's something they're always interested in something. I tend to wear t-shirts every day with different Disney characters on them, different cartoon characters, and it opens up a lot of conversations with kids and just gives them something to talk about. And I will say some of the adults I work with like them too, but finding something they're interested in and then talking to them about that. Oh, how would Cinderella do a blood pressure? What do you think she would do? And you can work that in and get it to work for your practice. And then using positive language is really key. Instead of don't move, which is what we tend to reflectively say when we're about to walk out of the room after we've gotten the position, don't move. You want to say things like hold still. They respond much more positively to when you are giving them something to do than when you're telling them not to do something. And then you can even,
Oh, I had a question. So often when these patients come to their visits, they have one or multiple siblings with them, often younger, but sometimes older as well. So I was wondering how or what strategies you have for involving them or interacting with them while you're trying to manage the patient themselves.
So we'll talk about the next part after developmental care is family-centered care. And when you are dealing with a child, you are actually caring for the whole family, whether siblings are there, aunts, uncles, cousins, parents, whoever it is who is part of that child's family system is who you are providing care for. And the reason for that, again, is trust. If the child sees you not treating their sibling well, they're gonna feel like you're not gonna trust them. Same with if they see you disrespecting a parent or something like that. Their primary source of interacting with the world is their family. Their primary authority source, their comfort, their safety is their family. It changes a little bit as they get older. In adolescent age, it's peers, but the family is very important. So it doesn't even necessarily take extra time to deal with the siblings as well. If they are asking questions, a lot of times that child, also the patient, also has the same question. They maybe just didn't say it first. So I will answer the siblings' questions. I will let them involve in care. Do you want to take your sister's blood pressure cuff off? Like, they can do any sort of things. When I'm taking temperatures, I often will take a temperature of everybody in the room, including people in care, to their comfort level. Let them play with all the equipment that we have that's safe for them to play with. That is a big part of care for kids.
Thanks.
Yeah. And then looping back to the using positive language like hold still, you can even make it a game for some of the younger kids. One of the big things we do a lot is, can you hold as still as a statue? And then now it's a game. Can I actually hold as still as a statue? Kids love games. They love to be challenged. A lot of them are very competitive too. I can do it. I can do better than a statue. I said that to one kid recently, and he said, no, I'm going to hold as still as a T-Rex is watching me, because the whole philosophy that if you hold still, a dinosaur can't see you. I think that comes from movies, but they now every time he comes in and we get his blood pressure, he holds as still as a T-Rex is watching him. Did I go backwards? Oh, age-appropriate language for different developmental care areas. So toddlers, you want to keep your explanations very brief and simple. Focus on the present moment. You don't want to prepare them for something that's happening in 3 days. You're preparing them on something that's going to happen in the next few minutes to hours. Using visual aids like dolls or stuffed animals for demonstration can do a lot to reassure them that they are safe. And for things like, instead of "we need to access your port," which even some adults won't know what that means, we say "there will be a poke." Now, for highly medicalized children who have had a port for years, we will say "we need to access your port." But for younger children where it's newer, we don't tend to use that language, not at first. And sometimes they will have their own language. Sometimes they will name their medical equipment and devices that they have, and then we use that name that they call it. If they call their central line Willie, we call it Willie, so that they understand what's going on. For preschoolers, you want to use simple, concrete explanations, answering questions honestly and directly, but avoid overwhelming details. So very simple things. Using play kits or simple picture books can help them understand what's going on and make them less afraid. Instead of we need to do a CT scan, you can say we're going to take some pictures of your body to see what's going on, because that's something they likely can understand. For school age, they're starting to understand more complex concepts and can handle more information. You're going to encourage them to ask questions to help them process. So instead of "you need to take this medication," these medicines will help you feel better. And then adolescents and young adults are capable of understanding complex medical information. You can allow them to ask questions and express concerns. Respect for privacy and autonomy is huge in this age group. You definitely need to provide for as much privacy and autonomy as possible, which can be challenging if we have to disrobe them for their treatment, but covering up as much of their body as possible will be important for their trust. Some other language that can be challenging: CT scan itself. You can say it's a circle camera that takes pictures of the inside of your body. Instead of anesthesia, you can say sleepy medicine, so you will not see, remember, or feel. Instead of a biopsy, taking a small piece of tissue to look at your body, from your body, to look at more closely. Instead of an IV, you can say special way to give medicine through your tiny straw or tube into your body. So just how you say things can make a big difference about their trust level, their fear, their cooperation. So some examples: SL was a 5-year-old girl. She had relapsed medulloblastoma when she came to us for treatment. She was diagnosed initially at 2 years old. She had a new lesion at 3 years old, had further disease progression at 4 years old. So even though she was 5, she came to us having never achieved urine continence, but she knew the detailed steps of sterile procedures. So this is where you can see where medicalized children can have advanced and regression at the same time. never having achieved urine continence for a 5-year-old, especially a girl, and this was even during the day, not just overnight, that is significant delay. And it was specifically relevant for us because we were doing CSI radiation, and we were wanting her to empty her bladder for fertility preservation because that helps the ovaries drop lower in smaller kids. But she couldn't do it because she had never achieved urinary continence. She was still in diapers. And the reason mom said is we just never, with all the chemotherapy and all the stuff over the course of the years, they had never just really gotten around to it with her yet. But she could go through the detailed steps of a sterile procedure. So for her, we talked about putting on the sterile gloves and using the special gloves and all the 15 seconds for the chlorhexidine to dry. She knew all of that, and we would talk to her with those language. So when we were talking about going potty and things, that was much more younger child speak. But when we talked about when we were going to access her port for her anesthesia, that was much more on an adult level. And we talked to her about the different things at the different levels for what she needed. Then we had BH, who was a 13-year-old boy. He had a lumbar chordoma. He had severe anxiety and autism to the point where after his surgery for his resection, he ended up in rehab, and partly because he was so anxious and couldn't handle the sensory things, and he was having such a hard time rehabbing himself. And even there, most of his notes were that he was uncooperative and inconsistent in his care due to his challenges that he had with mental health as well. He was also 5'9" or 1.75 meters and 153 pounds or 69.8 kilos. So he very easily looked like a 17-year-old child, which at that point you start thinking and treating them as an adult. But the gap between a 13-year-old boy and a 17-year-old is huge in terms of development. So also part of his problems were people looked at him and saw him as a more adult when he still needed to be treated as a child because he was not at that level of understanding, especially with his anxiety and autism needs. One of the ways I worked with him is when he came to clinic for his on treatment assessments, I always start with every child, no matter how old they are, no matter how they present, I start talking with the child and trying to assess the child. And it's not until the child proves that they cannot handle it or they do not want to handle it that I move to talking to the caregivers and trying to do the assessment more with them. But I started and I said, do you want me to speak primarily with you or primarily with your mom, who was his caregiver? And he said his mom. So every single week I would check in again and do the assessment. But I said, we're going to start with you. You have to tell me, do you have any pain right now? Because that's something mom cannot answer, and pain assessment is a big part of what we do. So every day I started, do you have any pain right now? He'd answer yes or no. And then I'd say, and now do you want me to talk more to mom about how you're doing or stay with you? And every day he said mom. So I would be doing an assessment with mom. We'd be talking about it, how he was doing, if he was eating, if he was moving, if he was pooping and peeing, all of those things. And one time we were halfway through the conversation and all of a sudden we hear, Mom, movement. And we were like, what? Because mom had just said she hadn't really noticed any changes since starting radiation, that he was doing very well and she was very pleased. And again, he says, Mom, movement. And we were like, what? And it took a little figuring out, but he was trying to get her to say that he was getting stronger, that he was actually able to take some steps without a walker. So even though he wanted me to talk to mom, he was still very clearly and very clearly wanting to be the correct information to be given to us, even though he didn't want to be the ones giving it to us himself. I met him where he was at and what he wanted, and we still got all the assessment pieces we needed from him. If you're not using developmentally appropriate care, so you are expecting more from the child than they are physically or psychologically capable of giving, that's going to have some negative side effects, including the child feeling helpless and out of control, a loss of trust, either because they were not told the truth or information was withheld. They can have behavioral changes, which tends to lead to less cooperation and more resistance. They can have impact on their coping, and they can have long-term psychological impacts. So children can develop chronic post-traumatic stress disorder from medical care. When they did studies of survivors of pediatric treatment, one of the things that they notice is the kids, now adults, 20, 30s, 40 years old, they don't remember much of their care. One of the things that they do remember is the pain they experienced. And that's pretty much all they remember is a lot of pain and a lot of fear. So we're doing a lot now, knowing that, to try and decrease the fear that they experience, decrease the pain that they experience, make sure that we don't push them over the threshold of what they can tolerate, to decrease the anxiety and fear. And if you are creating any of these negative things in a child by not doing developmental care, it's going to lead to a lack of compliance and even more time needed to get them through treatment than the extra time you might have to take to provide developmentally appropriate care.
Hey, Amanda, I have a question.
Yep.
A lot of times as radiation oncologists, we see patients when they're far along their path of care. So sometimes we get kids who already have trust issues with the medical system or already have fear associated with placing an IV or things like that. So I wonder how you address these already existing fears, or if you're able to turn it around a little bit in order to help them be more comfortable while they're getting care with us.
I will say this is one of the advantages you have in radiation oncology is you see the child every day. So you do have a big chance to make an impact on a child who already has medical trauma. And I have seen us do it several times. I'll talk about one story now. I think it's actually in my slideshow later, but now it's time we can talk about it. We had a kid come to us who had severe needle phobia, severe, significant needle phobia, and she was going to get anesthesia, for which we use a port. She had a port already implanted actually for chemo, and then we used her port for the anesthesia as well. So that means we're accessing her once a week. I think she got 6 weeks of treatment, 5 or 6 weeks of treatment. And we knew coming in that she had this severe needle phobia. They hadn't really been able to do much about it outpatient in the medical field where they were medical side, where they were only seeing her once every 2 to 3 weeks. But we were seeing her every single day, and we were accessing her port once a week. So every Monday, and de-accessing it every Friday. I was working with a child life specialist, and we actually planned for this patient to come an hour and a half before their appointment on the first day. And we gave this child significant amount of time that first day. And luckily we had the ability to do it. Our census was such that I had the ability to sit with this child as the child life specialist. And we just took it very slowly. We explained every step. We let her control when we were going to progress on to the next step of treatment, or the next step. She would give us permission to do the next step. And in between there was some negotiating. That first time took a really long time, but we never had to hold her down because she agreed to it along the way. By the end of the 6 weeks, and we did this, the port access the same way each time, although we started after the first time, we started setting more boundaries about how many choices she could have, how much she could allow delays. And then we also kept her trust every day, where we saw her, checked in with her, made sure she felt comfortable with everything that was going on with her care. We got her trust. By the last week of her treatment, she got access to port just like anybody else. I think it took probably about 10-15 minutes between the prep, the wiping down, the counting that she needed. She actually came back to us. It was planned for her to come back to us. We initially radiated her primary site. She had some surgery, further treatment, and came back, and we did the metastatic sites. The second time she came back to us, she no longer liked to sleep with her port and wanted to be accessed and de-accessed every single day. So we actually cured her of her needle phobia while she was here at radiation by taking that time, working with where she was at, and not pushing her back what she was willing to tolerate, even though she already had that needle phobia. So we made not only her care here better, but we made all of the rest of the care she's going to get for the rest of her life better. And you have the ability to do that when you're seeing somebody every day.
I see. Thank you.
Family-centered care, I already mentioned it a little bit, but that is, you're caring for the whole family because that child is part of a family system. They are not an independent agent. They can't live by themselves. They can't make their own choices. You are caring for the entire family. And a big part of this is also cultural competence. So knowing where your family's from, what their norms are, what they value, what they don't value, and just asking if you're not aware, because it's very possible you don't know the background of everybody who's coming in, checking in with them, seeing what matters to them, what their priorities are, and what they think is important for their child, how they think their child should behave, and working with them. In kids, it's a lot less about this is how we do things. like we usually do with adults. This is how we do things at the center. This is our standard. This is our process. And more about how can we do things with this family's priority to get this child through treatment. You don't ever break your own policies and procedures, but sometimes you go around, and don't go around things, that's not the right language, but you think about things in a different way with kids. Like one of the examples for that is when we are accessing a porta-cath, patients have to wear a mask because you don't want them to cough or sneeze on the site when you're going to access a sterile site to access the central line. We have a lot of kids, especially the sensory ones, but the younger ones, the toddlers and stuff, who cannot tolerate a mask. They will not tolerate a mask. They're going to fight you, not for the port access, but they're going to fight you for wearing the mask. So then you start thinking about, why do we have the kid wearing a mask? We have them wearing it so that they don't contaminate their site. What else can we do beyond our normal policies and procedures to avoid contaminating the site? And there are a lot of things you can do. Sometimes the parent is just or the child life specialist or whoever's helping you is literally just holding their head. Sometimes you don't even have to hold their head. You just put the iPad over to the side and the child stares at the side all the way. Sometimes then you can put a blanket up or a tissue up too, so that nothing air comes to breathe on the site. So you're still following what you need to do and not having them breathe on the site, but maybe you have to modify your standard a little bit to fit with what's going to work with this child and this family and what they expect. So examples for that, we had YW was a 5-year-old boy. He had an ependymoma of the frontal lobe. He came to us with some behavioral issues as well because his family had multiple stressors. It was a single mom. There was a lot of drama happening in the family, a lot of financial stressors, a lot of social stressors. And then he got a lesion in his frontal lobe, which did not help with his behavioral control. When he came with significant behavioral issues, including hitting, kicking, biting mother and some staff. Mom actually came, it was in the summer, so she was wearing short sleeves, but mom came to us with somebody had given her Kevlar sleeves, which is what the police wear to protect themselves from people biting them, because he was biting her so badly that she was getting injuries. This is a child that we had to figure out how to treat and get him through treatment. So with the work of the child life specialist, with nursing, with radiation therapists, with mom, and he did get some medications too to help him with some of his mental difficulties. We got them through treatment. We got him to calm down. He actually loved being here. And a lot of that was setting boundaries and working with mom. So this mom, by the time she got to us, was completely stressed out, completely exhausted, had so little left to give, and was so frustrated and was verbalizing that she didn't know what to do anymore. As well as things that we noticed and picked up on really easily early on was because she was so stressed out, she was saying things like, that's just him, he's just bad, he's just naughty, he can't control himself, I've tried everything. And he heard her saying that. Kids will do anything to get attention, even if it's negative attention. So what our staff, all of us, we came up with a group plan, the radiation therapists, the nurses, the child life specialists, all of us really made a big effort to catch him doing good things and to say, even if it was something small, you took that blood pressure cuff so well, you held so still, thank you. And we started modeling for mom all the time she could catch him doing good things, being cooperative, instead of just focusing and trying to control the bad things. And he setting a consistent schedule with him, setting behavioral boundaries, recognizing when he did well. When he left, no more Kevlar sleeves, no more biting or hitting or kicking. When I called mom for his 1-week follow-up, he said he wished he could come back. He missed us. So really working with the family, helping that mom. And this was a mom who was very open to any ideas and any suggestions because she needed the support. The other thing we did quite frequently with her too, especially in the beginning when she was so stressed out, was we'd tell her to go take a break. Like we'd say, I will sit with him. He will be safe. You go take 5-10 minutes so that you can come back to yourself. You can get yourself recollected so you have the resources within yourself to deal with some of his more challenging behaviors and are a little bit more rested. And just those little breaks, which since she was a single mom and she was living here alone with him away from their family support system because they were from out of town, those little breaks did wonders for mom being able to care for herself so that then she could care for her child again. So he was a very fun experience at the end. And then we had MS, who was a 6-year-old girl. She had rhabdomyosarcoma of the right orbit. She was a Canadian patient because they don't have protons in Canada, so they send their kids to us. but they had immigrated to Canada from Iran. So she had multiple cultural things. This particular patient was not told that she had cancer, and she had significant anxiety related to any medical care at all. It took her parents 15 minutes on the first day to convince her to walk in our center's door. And they also had some boundary issues with her in terms of getting her to do anything that they asked. On the very first day, walking through between the lobby and back to the treatment area with her, mom said, "Okay, come on with me." And she didn't move at all. And then mom leaned over to me and she said, will you ask her to come with us? Because she'll listen to you better. And when I did ask her, she did follow. So mom was having some problems parenting this child, and she was very resistant and very scared. And we think part of the reason is this was a very smart 6-year-old. She hadn't been enrolled in school yet. She didn't know her own name yet, but she was clearly very smart. She didn't know how to write her own name yet. She knew what her name was. And we all felt that she probably knew her parents, well, she knew her parents were withholding something from her, that they weren't telling her that she had cancer. They told her she had a bump that needed to be treated, and that is all they explained to her. So we think that was part of the anxiety, but this was a family value. They had talked to somebody who said, no, keep this from her. It will be better for her long term. It was a high family value. So we never told her that she had cancer. But we also never lied to her either. She never directly asked if she had cancer, but we told her she was getting radiation treatment. We told her that we were going to take care of her. And we worked with them to set boundaries, to work with care. One of the big things we did with this particular patient is she loved jokes. So we used that on a daily basis, and we came up with a rhythm. If you walk into the room, we can tell you a joke. If you get up on the treatment table, we'll tell you another joke. And we started limiting the amounts of jokes that we would tell her too, because she would use jokes as a delay tactic. She'd ask for one more, and soon you told 20, 30 jokes, and she still wouldn't get on the table, but we would limit it. And eventually we got her through treatment that way. Again, the first day getting her on the table took 45 minutes. On the last day, she ran into the room, hopped up on the table, and was ready for treatment. And she was another one when I called mom a week later after treatment to see how they were doing, if they had any symptoms or side effects. Mom said that she was really asking to come back to see us, that she missed us. So this was a child who would not walk in our front door on the first day, and then 7 weeks later was saying she missed us incredibly much and wanted to come back to visit. So you can make a difference in the family's lives. You can gain cooperation by taking a little extra time up front. If you don't use family-centered care, trust is broken. If the parents don't trust you, the child will not trust you. Sometimes the child will not trust you, but the parents still will. And then you're still in a good spot because the parents can help gain the child's trust and can help with the compliance. But you really need to have the parents trust you, the siblings trust you, and the patient trust you to get your best outcomes with the kids. And then the final different approach to care that we're going to talk about is atraumatic care. What atraumatic care is, you're trying to avoid any physiological or psychological pain in a child. At different developmental levels, they have different coping skills, they have different abilities to cope. And if you overwhelm their system, push them past what they are actually able to cope with, you can create PTSD. You can actually, if you push them past what they are physically able to cope with in terms of pain, you can lifelong alter their pain threshold. So well after they're done with treatment, they can have a lower pain threshold as an adult than other children. So you do not want to try and set them up for life to have more problems just because of the care you gave as a child. So big pieces of this is how you approach patients, and we'll talk about each of these things a little bit more too. But so approaching patients, the different developmental strategies, the family-centered care, gaining their trust, not freaking them out. Anesthesia is something else we do to provide atraumatic care, using child life specialists and thinking outside the box.
Hey, Amanda, I have a question for the chat from Mustafa Aliyu. As an oncology nurse, how do I ensure absolute immobilization on the CT simulator and the EBRT machine during treatment for brain tumors?
So there are two strategies. If the child is just developmentally too young, which there will be an age where there's too young, we use anesthesia. When they are so little, I don't know if there's another way to do it. Props off if people can do it, but when our threshold for cranial spinal irradiation is somewhere around 7 years old, if we think they can do it without anesthesia. Sometimes 6-year-olds can do it, sometimes 5, maybe that's really young. For not CSI, we've had some younger 5 and 6-year-olds do it without, but this is where you have to gain their complete trust. And this is where you have to also, distractions is big. And you just have to see if they can do it. So how we look at if we think they're going to be able to do it with anesthesia or without anesthesia is the first thing we look at is MRIs. Can they do an MRI and get the imaging that you need from an MRI without anesthesia? If they can do, that's one of the things then that lets us think that they can likely do radiation or the CT sim. If they cannot do an MRI without anesthesia to get good imaging, it's likely they cannot do treatment without anesthesia. If they haven't had an MRI, then we think about things like dental procedures. Have they been able to do that without some sort of anesthesia or sedation? A dental procedure is somewhat similar to what they do. They're going to have to lay on their back. They're going to have somebody standing over them. They're going to have to tolerate like things coming at their face. And then we also can do other, and if we're like borderline, we do things like having them lay on the floor, having them work with their parents to see if they can lay on the floor for 60 minutes straight without moving on their own floor at home in the comfort of their home. If they can't do that, they likely can't do it without anesthesia. If they can do that, they may be able to do it without anesthesia. It's a totally different thing laying on your floor at home. That's why we say 60 minutes, even though their treatment is likely not to be 60 minutes. It's a little bit longer that they would have to tolerate at home. But it's going to be scarier in our environment with people they don't know, in a room they don't know, that it's likely going to be very institutional with weird sounds and weird smells. So for our littlest patients, we do anesthesia. For the bigger patients, we do a lot of things. We sometimes try, for us at our center, for CT, if they are borderline, where we're not sure if they're going to be able to do treatment without anesthesia or not, we send them with anesthesia, even if we think they might be able to do without. There's 2 reasons for that. One of the reasons is we really want good imaging to plan their radiation. We don't want there to be any movement, wiggles, artifacts. So we want really good imaging to plan their planning, and we don't want that to be where we give them the trial of if they can do it or not. Another reason is we want to create their equipment in a position that our anesthesiologists are comfortable with. So what that usually means is how high that chin needs to be up so that their airway is going to be maintained if they are sleeping. So we want the equipment to be able to manage anesthesia just in case they are not able to be successful off. So we usually will sim the borderline kids who we're not sure if they can do it or not under anesthesia, just regardless. We also will often plan to do the first day under anesthesia as well, even if we think that we want to trial them off. The reason for that is the first day is generally longer, that we have a radiation oncologist come down and approve the images before we set them. Plus, it's the first time the radiation therapists are lining up that particular patient. It usually takes them a little bit longer to figure out exactly where everything needs to be and recreate that position. And as it goes on, that gets a little bit quicker and easier. The other big thing is that they will then know that they went into treatment and came out and they don't feel different. So that takes that part of that fear away of what's going to happen to me without treatment. So then the first time they're going to try off anesthesia, they have an idea of what it's going to be like after, and that they're not going to really experience any big scary thing during treatment. And then our policy as we're working a kid off anesthesia is they have to have 3 successful days in a row of treatment without anesthesia before we will cancel their anesthesia appointments. The reason for that is we've had some kids get through one treatment and say they're okay, and then they go home and they have a nightmare, or they freak out and they come back the next day and they can't do it. We've had 1 or 2, probably more than 1 or 2, who can do it 2 days in a row but can't do it in the 3rd day in a row. Almost everybody who's made it 3 days, actually I think everybody since I've been here who's made it 3 days then can make it the rest of treatment unless something else changes. There's been 1 or 2 cases where some kids have had such significant side effects that they couldn't, that we had to put them back on. But for the most part, if they can make it 3 days without anesthesia, then we think we will cancel their anesthesia spot. And we tell parents that we can always treat you without anesthesia in an anesthesia spot, but we cannot treat you with anesthesia in a non-anesthesia spot. Does that kind of answer the question? The littles are really hard without anesthesia or sedation because they will move. Some of the things we use to work to get them off anesthesia is the practicing laying still. Well, depending on their treatment area, a lot of the kids are brain or head area. We'll let them use squeeze balls because they can move their hands. They just can't move their head. And sometimes just letting them fidget with their hands. We'll let some adults do that too. Weighted blankets can be helpful. Music playing. All of our rooms have the ability to play music, so we let them pick what they want to listen to as a form of distraction and something they can think about other than just holding still. And then also they practice tolerating with the mask awake too. They try it on first sitting up just in the room, then they'll try it on laying down, and then we have them try it on flipping it into the table before we make them try and tolerate the 20 to 30 minutes with it clipped in. So we work them up in steps and prepare them each way, build their trust along each way, and that's how we do it.
We have a follow-up question from Mustafa. He says, if we use anesthesia, then it means daily anesthesia for the child for the period of the treatment sessions. Do we consider the safe cumulative dose of the anesthetic drugs? And thank you for the answers.
So we do, and this is part of the reason why as we gain their trust and as they get more comfortable in our center, we do try and get them off if they can. If they have any possibility of getting them off, we won't continue to use it if we think they can do that. And there is one of the cons of using anesthesia is there are clinically significant cognitive side effects from repeat exposure to anesthesia in children. And obviously, daily radiation is probably going to be one of the highest levels of repetitive exposure they're going to get during their cycle, during their treatment. But they're also going to need it for other things, surgeries and whatever else they're needing it for. So if there's when we put a pretty big effort into getting them off, we work with them for quite a bit. We do have a child life specialist who will work with them every day with different techniques and strategies of trying to figure out how to hold them still. We have a whole reward system here. We have a charity that's Hope for Henry, and they get $1 every day for treatment. And they'll also get money for other things too. And then they get to buy a toy with their money that they've accumulated. So we work that in. If you did want to wait, you get $2 today instead of just $1 today. So that's an incentive. If you hold still and do this thing, you get $2 today instead of just $1 a day. And then they've seen what they can buy too, so they get excited about that. That can help with them holding still because it really motivates them to want to hold still. We also have a Toy Day Friday where they don't even have to do anything, just making it through their whole week of treatment, they could just get a toy too. So giving them the rewards, building their trust. Some kids that we didn't think we're going to get off anesthesia, we did. And there's some kids that we thought we were going to get off anesthesia that we can't. But if they can, we do get them off because of the cognitive side effects. And it's not even just the cognitive side effects, the MPO times every day is challenging. We've definitely had kids struggle with nutrition and hydration being MPO, especially if they have a later time in the day. So they're spending more awake time, not being able to eat or drink. We want to try and avoid that if at all possible. So there's definitely drawbacks to anesthesia. We try and avoid doing it if we can. The bonuses for anesthesia is it definitely reduces movement. They're not going to move. They're going to be in the same position every day. That will be the easy management part. The other time we sometimes use it is if they are developmentally able to hold still, but there is some anxiety or trauma that's preventing it. Sometimes we will use it then too. And I have an example of that later of how we specifically use that too. But that is how we manage anesthesia. Here, I was talking a lot about port accessing. We don't do the inhaled anesthesia here. We use propofol. Our anesthesiologists like it. They think that it has quicker onset, that it has quicker, that they wake up quicker, so they're not spending as much time recovering, as well as they feel like it has fewer side effects. It doesn't tend to cause nausea, and they tend to have return to baseline normal a lot faster than the mask induction. We do have the ability to do mask anesthesia, and every once in a while we will, especially if a kid's coming in for SIM who is definitely going to need anesthesia, but they don't yet have some sort of central line. We will often do, and again, our focus is atraumatic care, we will do a mask induction to put them to sleep and then start an IV for their propofol infusion once they're asleep so that they don't have to have a poke. Although that can be a balance because some kids would rather have the poke than have their face shoved into an anesthesia mask. So again, that's evaluating your patient and what they're doing, but we often will do mask induction because we're going to do anesthesia anyways, and then start a propofol once they're sleeping. So when discussing anesthesia with a patient and a family, which of the following is important? The child will be completely sedated for all sessions, even if they can hold still. Anesthesia may affect nutritional status. The child's radiation dose will be adjusted based on the anesthesia used, or the child will need to be hospitalized each day they require anesthesia.
And Amanda, these are such great points. I feel like we could just benefit from your experience all day. The toy system really stands out as a clever way to get kids excited and motivated to cooperate for treatments. So I think that's something that nurses here could consider at their own centers. And they don't have to be expensive toys either. I think just
No, sometimes
lots of
they're not.
different kinds of toys so that kids
Yeah.
can see something that they like.
So this shows some of my lack of understanding of how other people practice. For my answer, I would have said anesthesia is going to affect nutritional status, because here we do get kids off anesthesia, but it sounds like that is, once some people have planned that, that is not what they do. So for some people, it would also be accurate if that's how your system, your center functions. But here our big concern is anesthesia may affect nutritional status because of the MPO, especially if they're also getting chemo and might have nausea. We do routinely give all of our patients ondansetron during their treatment if they're getting anesthesia. That's not so much from the propofol, because that tends to not cause nausea, but it's because the radiation might cause nausea, and also just hoping to keep them eating if they're also getting chemo or something. The radiation dose won't be affected at all based on their anesthesia dose used. Those are two independent things. And here we don't hospitalize. It's a day they come in, they wake up, they go home again. For us, it's our big concern at our center is the nutritional side effects that can happen with the anesthesia for acutely, and then obviously long-term cognitively, which is a question a lot of patients, our parents ask. And then that's a reason sometimes they will also do other incentives at home to try and get the child off anesthesia as well. Talked a couple times about child life specialists. I don't know that's something that exists everywhere else, but any licensed pediatric center in the US has to have a child life specialist at least part-time. What those folks are is they are trained in developmental impact of illness and injury. The child life specialists help children and families cope with the stress and uncertainty of illness, injury, trauma, disability, loss, bereavement. They do all the things through developmentally and psychologically appropriate interventions, including therapeutic play. They'll do preparation for procedures and education to reduce anxiety, fear, and pain. They are huge. They have a minimum of bachelor's degree, $600 internship, and they have to take an examination to become certified. They are my best friends in pediatric care. I love them. I'm a pediatric nurse. I am good at some of these things, but they are like the PhD to that level. They are the experts, and they really have so many trips and tips. And the other nice thing about having somebody like this, even if they're not certified, if you just have somebody who's really good with kids, who's really good at talking with families, is that she takes the time to sit with the kids while I'm off doing other nursing things. She will sit with them, talk to them, do the anticipatory guidance, do all the things to really win their trust, do a full family assessment about what works for them and what's going to be likely successful for them in terms of incentives and things like that. So it does free up some nursing time to go do more nursing related tasks. I still do a lot of this, and we work together constantly talking about kids, making up plans and how we're going to proceed, what our best strategies are for approaching this particular family, this particular patient, getting things. She will come up with whole care plans too for the radiation therapist that she will post in the treatment room about, these are the steps to get compliance with this patient. This is what makes them feel safe. These are the things. And sometimes it's as little as like the radiation therapist talking to the patient. The beam has started now. You are 25% through treatment. You are 50% through treatment. You are 100% through treatment. Sometimes just that knowledge versus sitting in a room by yourself is enough to get them through treatment. And she's the one who really digs deep to figure a lot of these strategies out. So if you have any ability to get that, is amazing. And then other things, thinking outside the box. There are different creative ways. People are creative. So think about what you think might be helpful with your population. On the upper left, that is I Am Ready. It's a virtual reality that exists by the Ricky Rubio Foundation. It exists in Spain from what I could find out. And it is basically just the kid goes through a virtual reality experience of what the sim and what the treatment is going to be like before they experience it. That helps reduce fear. It helps them ask any questions before they're on the table. It helps them feel more safe and really understand what's going to happen. Up on the upper right, that is actually one of our kids here. We paint all of the treatment masks. We have some artists among our staff. We ask the kids what they want on their mask, and we do it, from superheroes to dogs to cartoon characters to he made a full unicorn with a horn on it once. Like, whatever they want, it makes them smile. They take it home. They get excited to be Superman for the moment or so. That can do something alone. So that's a little thing that you could do. That's pretty easy, thinking outside the box to make it a little bit less scary, a little bit more comfortable. On the bottom left, this we don't have yet, but we are hoping to get it. It came out of Stanford and it's at a few other centers. Audiovisual assisted therapeutic ambience and radiation therapy, or AVATAR system. I think it probably came out of the theory that a lot of kids can get through an MRI if they're watching a movie. So they created a whole system of where they can see a movie, they can hear a movie, and it's radiation safe. So they can just sit there and watch a movie while they are getting radiation treatment. And that has gotten a lot more kids. They have studies that this has gotten a lot of kids off anesthesia and been able to save a lot of money by using this system. We're hoping to get it. And then other little things like making your treatment room on the right a little bit less scary, a little bit more welcoming. As you're preparing and doing whatever you need to do to get the kids set up, you can have, say, how many orange fish are in the room. And so now the kid is busy counting the number of orange fish and trying to find all the orange fish and interact with that, which can help gain compliance and help have them be a little bit more comfortable. So it's not always big things. Sometimes it's big things, but anything you can do to think of that is more child friendly, more fun, more playful is going to help your kids get through treatment. And then my examples for atraumatic care. This is the one I was talking about where we did it for trauma reasons. ED was a 14-year-old boy with a pelvic sarcoma. He was also autistic, so he had a lot of sensory issues. He had a very recent history of severe, significant sexual abuse, which had caused post-traumatic stress disorder. Had been a whole court case, everything involved. It was a pretty significant deal. We were radiating his pelvis, which would require him to be disrobed from the waist down for his treatment. Also had multiple family issues going on. He was going to flat out refuse. And at 14, he was also a large boy. We were not going to be able to hold him down. We were not going to be able to convince him otherwise to do it. He just was not going to tolerate being undressed in a room exposed. It just was not going to happen. So we did do anesthesia with him, even though he could hold still, to reduce that further psychological trauma he would have experienced. And then I already talked about the needle phobia girl. Gave that example already, but that was MH, and she was 5 when we did the anesthesia with her and got her through her severe needle phobia. Family care is not used. I did mention this already, but they can develop PTSD that they're going to have to cope with for the rest of their care. And then the pain thresholds can be altered for life in kids if you overwhelm their pain thresholds before they can cope with it. A nurse is planning for an adolescent patient receiving radiation. All of the following are examples of promoting atraumatic care, except A, allowing time for the family to pray with the patient before treatment. B, leaving the patient completely uncovered during treatment. C, playing music as a distraction. And D, talking to the patient during treatment to let them know how much time is left. Yeah, it seems most of you that we're right on track with that. Adolescents are very big into privacy and very concerned about people seeing them. So while you might have to uncover something for treatment, anything that you can cover, it will make, don't just leave them completely uncovered just because it's easier or it takes less time. It will be less traumatic to cover up what you can cover. So the take-home points from today, our kids are not little adults. They do have developmental, physiological, and disease differences that can also change their radiation planning sometimes. They do require different care, developmental approaches, family-centered approaches, and atraumatic approaches. And then not providing pediatric-specific care can lead to more challenges with compliant and completing treatment. I got some references and resources along with there. If you don't have access to Child Life at all, which most of you probably don't, there is a website, Child Life on Call, that you can look for tips and tricks and different developmental milestones. Association of Pediatric Nurses is global, and they have a lot of pediatric specific nursing. Most of it's medical, but just the strategies and tips about the different diseases and how to take care of kids is available there.